the aim of developing a specific tool for the sharing of knowledge in all the disciplines involved in esophagology. Well, we had our congresses, 15 since the beginning, with each time the in-depth dissection of a single subject by several hundreds of questions, each to be answered in 300 seconds, as you know, by one specialist who had accepted to come, sometimes from the other side of the world. And we have had the 16 books of our OESO Encyclopedia of Esophagology, now benefiting from the extraordinary advantage of worldwide diffusion offered by the New York Academy of Sciences with the simultaneous presence of our review articles on PubMed. Well, the list of our 11 previous discussions, and today it is from Brazil that the message of one of the pilot centers of the OESO platform will come, of course, again virtually. At its head, Professor Zilberstein, the next one, an old friend, an old friend, an active member of what we call, well, the OESO esophageal family. Many of you know what it means. True to the OESO mission since the very beginning, and he too, one of the pillars of the OESO-SEMPIRE platform. His charisma is impressive, as is his extended practice. And we will benefit today from the presence of some of his friends from Sao Paulo in various specialties, and also from Chile. I am pleased to say that all of these friends are also mine. Pise, Ceconello, the suivant, Braghetto, Demura, Salum, and others, with the panel to be completed with the voices of Stanford, with John Clark, oui, merci, of Dallas, and even further of Guangzhou with the vice president of the Chinese Motility Society, and even the voice of Kuala Lumpur, with Justin Lee, that I can see here in the panel, one of the scientific organizers of the next Asia Pacific Digestive Week that will be held there in Malaysia from August 19 to August 24. But now many of you in the virtual floor are anxiously awaiting the presentation of this case, which addresses many problems that we all know, those of the story of a long reflux disease and the evolution of a Barrett esophagus towards adenocarcinoma. And it is with a real pleasure for me to hand over to Bruno and to Sergio Shanovic that will make the presentation of the case. Thank you.
Well, thank you very much, Professor Julie. I think we can start, and all our friends here together, please interrupt us whenever you want to make your comments and to share also your experience in each point of this presentation. It's a free talk, so we can discuss it and share our experience with Barrett and adenocarcinoma. Thank you to all my friends to share with me this presentation. Please, Professor Shachnovich, let us see the case.
Professor Julie, Professor Bruno, first of all, I want to thank all of you to share this presentation with you, and so I can learn something from the colleagues and the specialists that we have here. I will start the case. The case is a male patient, white, 65 years old, a non-smoker patient, and he refers heartburn and regurgitation for 20 years, without any dysphagia, any complaint of dysphagia, and without respiratory symptoms. He used regularly PPI, 60 milligrams of dexlansoprazole for the last 3 years, but he have a very long history of PPI usage. He didn't complain about weight loss, and he has as comorbidity just high blood pressure, taking omeprazole. His actual weight was 85 kilograms, and the body mass index about 25 kilograms per meter square. And he was referred to our service, showing these pre-exams, and this was an upper GI endoscopy performed in another service that showed a hiatal hernia with 2 centimeters, a long Barrett's esophagus with 5 centimeters with nodular area, and the biopsy show high-grade dysplasia in a Barrett's epithelium. He performed there in the other service also a CT scan and an echo endoscopy with no remarkable findings. So he went referred to us, and we start with an endoscopy at our service that show a hiatal hernia, minimal hiatal hernia with 3 centimeters, C4-M6 Barrett's esophagus with nodular area, with microvascular pattern alterations. The biopsies, the biopsies show high-grade dysplasia in Barrett's epithelium. Here we can see the video from the endoscopy at our service. So Prague C4-M6 Barrett's esophagus from 30 to 36 of the upper dental arc. We can see 10 millimeters nodular area with the light lightening at the anterior wall associated with irregular adjacent mucus of the right lateral and posterior wall. The BLI chromoscopy and magnification shows the capillary dilatation with irregular areas at the anterior, right lateral, and posterior wall, lengthening about 2 centimeters.
Sergio, let us Professor De Mora to comment the video, please.
Okay, thanks, Professor Silberstar, for inviting me to participate in this important meeting. In this case, Dr. Sergio said about the lesion is a 10 millimeter nodular area. It's a white lightnet, and the anterior wall is associated with regular adjacent mucus at the right lateral and posterior wall. BLI chromoscopy and magnification demonstrated the capillary dilation with irregular areas at the anterior, right lateral, and posterior wall, lengthening 2 centimeters. This is the aspects is possible to identify the vascular alteration, and the irregular patterns. This is a characteristic suggests the adenocarcinoma in Barrett's esophagus in the nodular area.
Thank you, Professor De Mora. There is someone who wants to comment about the endoscopy, or Professor Italo about a long Barrett esophagus. Professor Ceconello, who wants to comment anything about this dimension of the Barrett esophagus, and if this has any importance?
Bruno?
Go ahead, Italo. Yes.
Yeah. Thank you very much, Bruno and Dr. Julie, for inviting me to participate in this meeting. Concerning your question, the endoscopy for me suggests, for me, in my opinion, a large area of alteration of the mucosa. If
Italo, just a moment. There is someone with the phone open. Please, who doesn't talk, just close the micro, please. Okay, Italo, go ahead. Thank you.
Yeah. Again, thank you, Bruno. Thank you, Dr. Julie, for inviting me to participate in this meeting. Regarding the question, when I see the endoscopy, for me is that the visualization, the image suggests the presence of adenocarcinoma because there are nodular and also deep lesion like erosion or like ulcer. I think that the hypothesis of the diagnosis of endoscopy is to exclude adenocarcinoma, the presence of adenocarcinoma. And the other question is, because this area of abnormal mucosa is very large, and then that finding support the presence of, at least exclude the presence of adenocarcinoma.
Thank you. Thank you. We can go ahead. Any other comment, please? There is anyone who wants to make any comment about the endoscopy? Okay, thank you. Please, Sergio, go ahead.
Okay, thank you, Professor. So the lesion was biopsied, and the histopathology showed the nodular elevated lesion, moderate differentiated adenocarcinoma, superficially invasive associated with intestinal metaplasia. At the posterior wall, they performed another biopsy that showed moderate chronic inflammatory process and complete intestinal metaplasia without any atypia, without any dysplasia. So the patient was referred to a ESD procedure at our service. And here we can see the endoscopy before the ESD procedure. And now I will show just a very fast video of the ESD. We can see here the marks of the ESD area that will be performed.
Dr. Mora, do you want to comment the video, please?
Yeah, in this video, it's possible to identify the section for the submucosal and near the muscular. It's possible to understand the technique to inject and resect. And in this case, I perform this procedure and I remove for the lesion the anterior wall involved the right lateral and posterior wall too. And totally 6 to 70% of the circumferential. All the margin include in the resection, and the final aspect is possible to identify the reminiscent Barrett's esophagus in left area, left wall.
Okay. Thank you. Who wants to comment the decision of performing an endoscopical removal of this lesion? Professor Cicconiello, do you have any comment? Anyone wants to make any comment about the treatment decision?
No comment. I think the lesion was not so lethal and not good only for resection of the mucosa. And the indication of ESD was very nice and very well conducted by Dr. Mora, who is a very good specialist in these kind of resections.
Dr. Jung, Dr. Lee, Dr. Matthew Reed, Dr.
Thanks. I've just got one question, and it relates to the endoscopic ultrasound that you performed. In this instance, what was the purpose of that ultrasound? Was that to assess for nodal disease, or was it to assess the depth of invasion of the tumor to see if you could do an ESD?
In this case, the endoscopy ultrasound showed the lesion restrict for the mucosa, no invasion for the submucosal tissue. It's not necessary to perform the endoscopy ultrasound in this case, because sometimes you have the inflammatory area and the final diagnosis. Sometimes you'll mistake it's a tumor or not tumor. In reality, in this case, the idea is to look for the lesion and analyze after you remove if you involve or not submucosal tissue. The initial aspect is restricted for the mucosa.
Professor Matthew, just to tell you that the ultrasound, the echo endoscopy was performed in another service before the patient was referred to us. So yeah, you usually after the endoscopy showing these patterns of the nodularity, we send the patient to ESD directly. We don't have the echo endoscopy as the part of the diagnosis process.
Okay, thank you.
Thank you, Sergio. Please.
May I have a question, please?
Yes, please.
To ask the endoscopies, if you see elevated lesion like this, is not an irregularity, or is a good lesion and protrusion to the lumen. And what do you say, just looking to the aspect of the lesion, do you suppose that this lesion may go to the submucosa also? Just look into the macroscopic lesion. What is the certainty of my saying here? Do you think that an elevated lesion like this is only a regularity or an elevated lesion? And what is the percentage of chance to have a submucosal lesion?
In general, when you identify the nodular lesion, the involvement from submucosa is a high percentage. But in this case, specifically this case, the nodular area is not too much, and the aspect for the alteration is only the patterns in the mucosa, not the aspect for the involved the submucosal tissue. No depression, no folds, only the nodular area. In this situation, it's adequate to indicate the ESD before then you decide about the surgery or not. Because when you remove the tissue, it's a totally by ESD. It's possible analyze this case with the pathologist, it's involved or not. It's necessary the surgery is complementary for the treatment.
Thank you very much. Let's go ahead, Sergio, please.
Bruno.
Short one,
Yeah.
short one.
Yes, but in the other endoscopic visualization, not only was possible to see elevated lesion, also a component of depressed lesion. And the area was, I saw that it was more large than that are seen now in this vision.
Okay, good comment. Please, Sergio, go ahead.
Okay, here
Can I ask
we
one more
have.
question, please?
Yeah, of course.
Yeah.
Just from a technical point of view, it looks like the nodule was very close to the hiatus hernia. Did that prove to be difficult when you did the dissection? Like, did you have to do it in a retroflexed view, or could you do it from above?
You perform when your first incision is a retroflexion view, and you cut the fold, the gastric fold, and you the reposition for the scope in the esophagus and perform the DSD. It's not difficult, it's very easy.
I have a question to all of you. Who would perform correction of the hiatal hernia after this procedure? Nobody?
No.
No?
No.
At the moment, nobody.
Andrew, you said no.
No, I'm a
Andrew,
gastroenterologist. But no, I think that it's very important to control the reflux, extremely important, and they will need twice daily high dose PPI. But in my opinion, I don't think fixing the hernia is any better in most patients. If they are not responding to high dose PPI, that is when I would look to ask Matthew to repair the hernia. I do have a question. It's obviously quite a big resection, and I can see that there was a big area that looked abnormal. Some of it depressed, some of it was just a bit bumpy. but it looks like it goes right down to the gastroesophageal junction and even perhaps into the hernia. I'm just wondering, to the endoscopist, I mean, how confident were you that all of the abnormal tissue was removed? And did you take any biopsies from the edges to see what was in the adjacent tissue that was left? And how far down into the hernia, onto the GI junction, did you go with the resection?
Eduardo, do you have any? No, your micro.
Yeah, no, I don't have a comment about it because I didn't understand all the content.
Were you confident that all of the abnormal tissue was removed, and especially at the gastroesophageal junction? Sometimes it can be difficult to tell if there's abnormal tissue kind of extending even into the hernia. Was that difficult to tell?
Okay, I understand now. Okay, thank you for your your comment. In reality, when you analyze for the gastric fold near the Z line, it's very important to use not only the chromoscopy, but to use the other techniques. I use the SD, oh my God, remember the acetic acid. Acetic acid, and with acetic acid, it's possible to define the normal tissue from gastric fold in the area from metaplasia. I use this technique when I define about the limit from the tumor.
Thank you, Eduardo. Professor, you had a comment, please.
Yes, this is Hun-Yong Jung from South Korea. I'll comment, and I have a question. The comment is, this patient has a considerable size of hyperhernia. So initially, we can do circumferential ESD from this proximal margin to enough space at the cardia. So some patients with the circumferential ESD can make stricture after procedure, but for this patient has enough size of hyperhernia, so maybe very low percentage of post-procedure stricture. So I would recommend the circumferential resection. And second question, the question is, what do you further plan after this partial, yes, almost 3/4 circumferential ESD? So, do you have any plan regarding the ESD at the residual, the 6 o'clock side, better as follows?
Yeah, your comment is adequate, it's totally adequate, but the problem, when you remove the circumferential stricture, the stricture is 100% of the patient. You change for the problem, the barriers for the stricture, and sometimes the patient need many sessions for dilation. And on the other hand, when you perform DSD with adequate resection, the reminiscent barriers is possible to complement this treatment with radiofrequency ablation. This is the idea about the treatment. But if you remove all the lesions, perfect, no problem. The problem is the stricture, not the barrett's esophagus. But it's I need to discuss if I have the epithelium, all the epithelium, the high-grade dysplasia or adenocarcinoma, as the patient submit a surgery or circumferential ESD. But in this case, the other biopsy show only metaplasia, not high-grade dysplasia. Because this, I keep the tissue from Barrett's, reminiscent Barrett's, for the second time perform the RFA.
Oh, okay.
We have a
That
comment from
maybe,
Justin Lin as well.
makes sense.
Hello, hi. Yeah, it's a very interesting case. You know, a typical Barrett's and with a nodular lesion, and obviously the ESD was performed very well. Although exactly like I agree with Andrew, whether the resection was complete. Obviously, the decision to do a ESD versus an EMR partly would depend on the size. Anything larger than 2 centimeters would be considered for the ESD. Although there are certain countries that are more comfortable with doing EMR, or the fact that not all the country will have the expertise in doing an ESD. So this would be something to consider. Maybe one of my question is that whether this lesion will you be able to do a EMR? So that would probably be one of my question. My other comment is with regards to Professor Bruno on whether there is a role for fundoplication. I think this is an interesting question, partly because if we were to leave this lesion, there is a potential chance that it will recur. Now, the question is like, do you want to do a fundoplication to prevent subsequent incident esophageal adenocarcinoma? Probably not. I think data does not suggest that fundoplication will prevent any new esophageal adenocarcinoma. And therefore, I agree with a comment by Andrew, where I think PPI would be the first consideration. So that would regards to the comment by Prof. Bruno. My third comment is with regards to whether there will be a role for ablation. I think the question was partly answered because I think Prof. Jung did mention about circumferential, and if you not to do a circumferential, would there be a role for ablation in such a case? Yeah, thank you.
Thank you. Please, Sergio, let's go ahead. We have a lot of other things to discuss.
Okay. So here we can see the pictures of the endoscopy, the nodular lesion at white lightning. Here we have at the letter B, the optical chromoscopy showing the nodular lesion with irregular low net microvasculature. Here we have the border area between the normal and capillary irregularity. And here the final view of the ESD. And here we have some interesting data about the histopathology. So here is 10 times methoxylin and eosin, showing the nodularity and all the presence of the high-grade dysplasia adjacent of the nodularity with the preservation of the submucosa. And here we treat the specimen with KI 67 and P53, and that shown the positive in the lesion, and in adjacent areas there are no positively about the immunohistochemistry. Here we have another picture of the histopathology with details showing the preservation of the submucosal layer here, and here a zoom at the nodular lesion. And the histopathology showed a total sampling of 3.2 per 2.7 per 0.2 centimeters, and the polypod lesion measuring 0.7 per 0.7 per 0.1 centimeters. And the mucosectomy sampling show moderately differentiated adenocarcinoma, invasive to mucosa muscular layers, unidentified perineural and angiolymphatic invasions, three margins of neoplasia, three borders. The anatomopathological staging was PT1A. So the patient was sent for follow-up of survival endoscopy after 2 months. And this endoscopy showed, oh, I'm sorry about the sound, showed the post-operative status after the ESD without any stenosis. There is also an ulcer in distal esophagus in the previous location of ESD. The reminiscent columnar epithelium area in distal esophagus is shown without any irregularity, and a 3 centimeters of hiatal hernia, a type 1 hiatal hernia of 3 centimeters. I will show some pictures also of the endoscopy. I don't know if Professor Eduardo Moura wants to comment about these pictures.
In this picture, demonstrate in the, can you identify my arrow? No?
Yes.
Please, yeah, okay. In
Professor Eduardo?
Can you see? No? Okay, the second sequence from the pictures. In the second picture, it's supposed to identify in the anterior wall and right lateral ulcers in repair the ulcers, and the left wall you identify the reminiscent Barrett's esophagus. All the lesions identify as scars after ESG and the reminiscent Barrett's esophagus. No more nodular lesion and no more other suspect lesion in these pictures.
Did you take biopsies?
Yes.
Yeah. I repeat the biopsy in this case and one more. Sergio?
Here at this endoscopy, we didn't perform biopsies because of the ulcers and the inflammatory process. But after 1 month, here was the final. Because after 1 month, we did another endoscopy that showed columnar epithelium islands at the anterior wall from 33 to 32, irregular elevated areas at posterior wall. We can see here the picture that were made many biopsies. Near the GA junction, columnar epithelium at the left posterior lateral wall, lengthening 1.6 centimeters. We performed biopsies also. And at the anterior and right lateral wall, elevated and irregular areas with 1 centimeters, and we performed biopsies at all. And 3 centimeters hiatal hernia without any strictures. Here was the pathology from this endoscopy that showed some fragments of scamocolumnar epithelium transition with moderate active and specific chronic inflammatory process, and presence of complete intestinal metaplasia with reactive glandular alterations, but the absence of dysplasia in the 3 samples that were taken by the endoscopies. Anyone want to ask something or to discuss?
What would be the follow-up of this patient? Who wants to comment about the follow-up? Would we repeat the endoscopy after 3 months, 1 year, 2 years?
Okay.
What would be the follow-up of this patient?
The routine in our unity, I repeat the endoscopy in the first year 4 times. After the SED, 3 months. After 6 months, 9 months, and 1 year. After 1 year, I repeat 2 times. It's 18 months and 2 years. And after this, I repeat the procedure once a year.
Everyone agree with this this follow-up?
Bruno,
we agree about it?
Bruno,
Italo?
before answer your question, I am very worried because two things. Because the endoscopic image of the control after are in very irregularity and depressed lesion. I don't know how many biopsies and where were taken the biopsy, because I am see here, ¿no es cierto, depressed lesion, irregularity, nodality, almost, yes, almost 50% of the circumference. And then the question is, where were taken the biopsies? Because I think that is very, very alterated epithelium. And then the question is 2 months, 3 months, 6 months. I repeat more biopsy very early, because the endoscopic visualization suggests a persistent alteration, abnormalities. That is my comment.
Could I comment?
Specific area that you comment is ulcers after ESD, and the limit from the gastric fold is adequate. Your comment is regular area, but you have in this area inflammatory aspects, because you remain the ulcers after ESD. But all the suspect area, I obtain minimal 4 fragments in the specific point. And I repeat the procedure, same comment, after 3 months, 6 months, 9 months, and 1 year. But when we identify this area is a suspect area, I obtain minimal 4 fragments, in general, more than 4 fragments, and analyze the area about its regular, if alteration for the microvasculature, alteration about the patterns. In the specific alteration area, I obtain many fragments.
Okay, thank you. Sergio, let's go ahead.
Okay. So after this, the last endoscopy, the patient was referred to return in 2 months to perform surveillance endoscopy with Seattle protocol biopsies, followed to a protocol of RFA ablation if there is no lesion, no dysplasic lesion, and for display or negative screening for dysplasia at the reminiscent epithelium. But the patient have some problems to return regarding the COVID pandemic. So the patient refused to perform the surveillance endoscopy at our service. We called him to come back for the surveillance, but he didn't return. And after 14 months, he called us complaining of mild dysphagia. So the patient returned to our service to perform another endoscopy. And we see this endoscopy, this postoperative status after ESD without stenosis, elevated lesion at the anterior wall of distal esophagus with 1.5 centimeters, the biopsies named A, an ulcer infiltrative lesion at the right posterior wall of the distal esophagus with 2 centimeters, biopsies named B, and a 3 centimeters hiata hernia. Here I will show, first of all, the lesion.
My comment is this aspect is an infiltrative tumor. It's adenocarcinoma, and it's totally different than the aspect before, after the last control. And identify the infiltration for the gastric fold in this area. The lesion is the distal esophagus, but involve the gastric fold more than esophagus in this image.
You can see here some irregularity and the ulcer here, nodularity, and the ulcer just in the distal esophagus. So the biopsies show, yeah?
No. Okay, no problem.
No? So the biopsies showed an invasive moderate differentiated adenocarcinoma at the squamous columnar junction and a poor differentiated carcinoma at the squamous columnar junction with intestinal metaplasia and head-grade dysplasia at adjacent columnar mucosa. So the patient was referred to the staging exams, some exams. So we perform a PET-CT from this patient that shown just a lesion, a 2-3 centimeter lesion at the GA junction, and the PET-CT show a SUV maximum of 11.2 without any nodularity or any suspicious lymphnodal invasion. Someone wants to discuss or to ask something?
Did you perform staging with a laparoscopy as well, a diagnostic laparoscopy?
No, after this exam, we didn't perform. We sent the patient. We are thinking about a T2 lesion in the GE junction without any suspicious lymphnodal invasion. So we send the patient for the surgical treatment.
Dr. Rubens, would you like to make any comment?
Yes, the problem...
Professor Rubens, just a moment. Professor Rubens is the chief of the esophageal service of our hospital. And besides being a brilliant surgeon, he has a very large experience in adenocarcinoma. So go ahead, Professor Rubens.
Thank you, Bruno. The major problem, it is a very unusual evolution and with a different tumor, in my opinion, and not differentiate tumor, a very aggressive tumor that were out of our action at that time. Of the ISD or the follow-up since the very beginning. It's difficult to understand where we lose and when we lost that area, but probably it was since the very beginning because of this very rapid evolution and uncommon evolution.
And what will be the treatment decision now? Who will?
Bruno, let me just tell that also due to the pandemic in our hospital was referred to treat COVID as the major action, and some changes happened here in this period. First was the endoscopic follow-up of the patients, and the second was impacted the treatment. We do in those cases the float before, but we had not the opportunity because of this evolution, and we referred immediately to the surgery.
At that time, we have to remember that at that time we are not able to send the patient to the oncology treatment because they were closed about the pandemic. Yeah, Rubens.
So if not due to the atypical situation, we would perform an oncological treatment and a neoadjuvant oncological treatment with float therapy. unfortunately, due to this unusual situation, we had to perform upfront surgery. That is, so what it happens?
So the patient was sent to the surgical treatment, and we performed a subtotal esophagectomy with lymphadenectomy with gastric pull-up. Here we can see the specimens before we open, and here we can see the ulcer and the lesion going through the gastric folds, as Professor Eduardo Moura mentioned at the endoscopy. The patient had an uneventful postoperative evolution.
It was done by laparoscopy or robotic surgery?
No, it was performed by thoracoscopic and laparoscopic approach with cervical anastomosis, a gastric pull-up with cervical anastomosis as we perform. A macule, yeah.
Do you want to make any comment, Rubens?
We have here two hospitals. One is the central hospital where this patient was operated on, and the other is the cancer hospital. And the robot system we have just in the cancer hospital. And due to pandemic, this patient was operated in the general hospital. And because of that, it was performed by a thoracoscopic and laparoscopic approach. We often do by robotic transthoracic approach. We always do McKeown procedure with cervical anastomosis. And this is what was done for this patient. And thoracoscopic and laparoscopic dissection and cervical pull-up of the stomach.
I think we can have now the opinion of our commentarist here. Is someone who would like to make any comment about it? What about surgery? What would we do with or without chemotherapy? Is there any comment? Someone wants to make any comment?
I agree with the decision in light of COVID to proceed directly to surgery. I think we would have done the same thing. For this tumor, I would have done an Ivor Lewis. We do a chest anastomosis. And the other thing, I don't know if you did this, but we would also do a pyloroplasty. Some of these patients have issues with delayed gastric emptying, and if you don't have access to endoscopy, it limits your ability to either inject Botox or do a balloon dilatation down the track. So at the time of surgery, I'd probably do a pyloroplasty in this instance. And I think just to comment about this case, obviously, I think when you start treating a tumor endoscopically, obviously ongoing surveillance, regular surveillance and treatment is a requirement. And I think that needs to be explained up front to the patient. And obviously COVID prevented this. So I just wonder for future patients in this situation, are you still offering endoscopic management, or do you say that because of COVID, we can't offer the surveillance, so we can't treat up front endoscopically?
A very good question. I think we talked to the patient about the surveillance and the importance of that. But here in Brazil, and the patient lives about 1 hour from our center, and we have a lot of I can say he has a lot of fear to come here because our center was the center of the COVID treatment from São Paulo. And the patient, we call the patient and the wife and the family, and they just want to come back. But we started treatment with the ESG before the pandemic situation. Yeah? So we get this situation after this time. And we don't can get the patient back to perform the surveillance. But I agree with you. Otherwise, if I know that the patient will not come back to the surveillance, I think probably we will ask to go directly to the surgeon.
Thank you. And what
Yes,
was the pathology? I don't think you've shown that yet, have you?
Okay. Professor Ivan Giaconello, want to comment something?
Yeah, I want to comment something. Yes, I have to tell you that for COVID reasons, 700 beds of our hospital were changed for COVID, and most of our OR were changed to intensive care for COVID. So that was very difficult to treat patients. And the endoscopy service was a lot of service because of patients, mainly for colorectal endoscopy. So this was very difficult to treat patients. But that's not I'm not telling these things. Uma desculpa.
It's not an excuse. It's not an
excuse for that. But the patient many patients didn't want to come to the hospital because our hospital was the center of. Even if we changed to our Institute of Cancer, there was also many patients with COVID. So it was very difficult to follow this patient and to make the right treatment. But I want to come before the treatment and discuss what were the results of the mucosa resected. Apparently, there was no tumor, but I understand that the distal part was an undifferentiated tumor, and the proximal part was a moderate differentiated tumor. And if you go back to the data from Professor Takubo, a pathologist from Tokyo, and he found in these cases that in 6% of the cases you have in the same platform, you have differentiated and undifferentiated lesion. And they showed also that in 71%, and this is also our cases, the lesions are undifferentiated. So I'm also very worried when you do resection by endoscopy to see that the lesion, if the lesion is really well differentiated, because also we have 40 cases of resection of adenocarcinoma with Barrett's, not from our follow-up of Barrett without carcinoma, but patients that come to the Cancer Institute with adenocarcinoma in Barrett's. And in these cases also, undifferentiated lesion is elevated. And the recurrence, we have a case in the past that somebody make outside a mucosectomy over the lesion, and he didn't find one lesion, and we make a lot of biopsies, so we didn't find the lesion, and it was there. And it was there and come again. So undifferentiated lesion has a rapid revolution as this case. And I think this case is from the beginning an undifferentiated lesion. Maybe the part of the esophageal mucosa is something with our Japanese descendant pathology, Dr. Iria, showed in the past that some of these intestinal mucosa is a microtubular mucosa, and this type of tumor, they act like an undifferentiated lesion. So we should take care of the biopsies and see more and more, and to take care, because I think that some of the tumor stayed there. There was another lesion, was the same tumor, not identified in the same endoscopy. And the second thing here is, okay, no chance to do preoperative chemotherapy in this case, but this is an esophageal cancer I would like to discuss with Professor Salum, who is the chief of our esophageal surgery group in the last 15 years in our department, and discuss if he would resect the lymph nodes, paratracheal lymph nodes, as this is an esophageal cancer, type 1 adenocarcinoma, or only infracarinal and periesophageal resections. As you do by thoracoscopy in this case, please discuss why you didn't dissect paratracheal lymph nodes.
Before that, Ruben, just a moment. Dr. Dr. John, where is he?
Oh, here. Thanks so much.
Yeah,
This was
John, do you want to make a comment, please?
yeah, one quick comment. I think this was a very, very well done case, and technically your work was beautiful on it. My question for perhaps after this discussion would just be looking back at the outcome and knowing where things were at the start. In retrospect, do you think there's anything differently that you would do now if you were seeing this same case again then? Thank you.
Okay, Rubens, with you.
Yes, the question about the upper part of lymphadenectomy inside the thorax. This is a good question. In CVERT 1, we often do just to the middle part of the thoracic area, just to the infracardial nodes. We are dissecting, and we go up to the peritracheal nodes just in case if you find this disease in the preoperative staging. So we can do with this type of dissection, Ivor Lewis or McKeown. Traditionally, we do McKeown in service and in those cases. So we are not routinely dissecting the peritracheal nodes in adeno, except in the case we have a commitment.
And then, can you answer John Clark's?
I think there are another questions from Professor Bragueto. I don't know. Do you want me to finish the case before?
No, I don't.
Yes.
Yeah.
I agree with the program surgery. We also perform thoracoscopic and laparoscopic approach for these cases with cervical anastomosis. My question was how many lymph node, how was the lymph node harvest in this case? How many from the abdominal area and the mediastinal lymph node resection? How many lymph nodes you harvest in these cases?
Okay, I will show just in front the histopathologic result, but just the patient shows an uneventual postoperative evolution. He was discharged from the hospital at 8th postoperative day, and with oral diet, with good acceptance, and currently he is in adjuvant treatment in the 6th cycle. And here is the histopathologic result. It's an invasive adenocarcinoma, poor differentiated. The location, the epicenter of the lesion was 0.5 centimeters from GA junction. The size was 1.9 at the largest size. And the depth of invasion was the adventitious with maximum of 1.4 centimeters. There are positive lymphatic invasion, venous invasion, and perineural invasion. So the patient was referred to the chemotherapy. Surgical borders were free of malignance. The lymph nodes was dissected was 3 positive lymph nodes in 36. And all of the positive lymph nodes were periesophageal lymph nodes, 3 from 7. I don't have the answer, Professor Bragueto, here, but there were 23 lymph nodes in the abdominal part, in the chain number 1 and 3, and in the epitogastric ligament, and after the celiac trunk, and the other 13 lymph nodes were from the thoracic part. And the final stage was PT3 and 2 tumor.
Okay, thank you, Sergio. I would like also you to comment, and also Professor Ceconello to comment, the follow-up of our Barrett's patients in the long-term follow-up. I know that you have a great experience with that. You could comment it, and also the treatment options that we perform for those patients. Please.
Okay, thank you, Professor. I don't know, Professor Ceconello, you want to tell something?
Go ahead. Go ahead.
Okay, okay. We have actually, at this time, about 600 patients in following up after or Nissen or clinical treatment with PPI. We prefer to send the patients to the surgical treatment with a long Nissen procedure. The patients who have not any indications of dysplasia, but there are some cases that the patients are following with clinical treatment with PPI because or they show obesity at the diagnosis time, or they show advanced ages, or something with a weak motility, esophageal abnormality. So these patients we keep on surveillance with PPI usage. Normally, regularly, we perform with 40 milligrams of omeprazole at our service. And we are following these patients every 2 years. Every 2 years we perform because of the protocol at our ambulatory, and I am taking the surveillance of these patients since 1995. So this is our experience. We have now 15 patients with high-grade dysplasia of adenine that evaluated after our surveillance, and another 30 patients with low-grade dysplasia. So they are on follow-up with endoscopy, MR, or ESD when necessary. And we are now following these patients for about a median 10 years of median follow-up. I don't know if Professor Ceconello wants to complete something.
Oh, I think that the follow-up is changing with the years now. With the development of endoscopy, we can follow the patients and watch better the patients. But if you went the patient to surgery, and like this case, this is a long Barrett, and we didn't have the opportunity in this patient because he arrived with the elevated lesion. Yeah. But if you have a long Barrett and you make a fundoplication, and you only do fundoplication if you don't have a BMI over. So in those cases, we do a fundoplication, a Nissen fundoplication. And in these cases, as the follow-up, that Dr. Sergio is in charge of this outpatient follow-up from more than 20 years, we found 6 cases. I discussed this with Italo in the meeting last week. 66 patients. This data are common for all our group of esophagus. And in these 66 patients, we have 3 cases, 2 cases of cancer, one with 3 centimeters of Barrett and one of 5 centimeters of Barrett, 60 months and 72 months after fundoplication. That means occurrence of 3.0% in long Barretts. In short Barrett, only 1 case of cancer, 2 centimeters, and 22 months after surgery, which means 0.6%. So these are our data. You have to follow the patients, and we have a special follow-up, and we follow these patients each 2 years. And you can now, Dr. Sergio is making the last data of this comparison is not randomized because they are not randomized, but we are following both patients with PPIs and full duplication. Maybe can previews tell us what is happening in this casuistic of follow-up.
Okay, thank you, Professor Ceconello. From the floor, any other question?
Yes.
Would you like?
Yes,
Denis?
yes. I have a question about the follow-up. The follow-up after removal for cancer is mainly focused on the oncologic aspect to detect a recurrence of the tumor. But as we remove the EG junction, we create we improve gastroesophageal reflux after an Ivor-Lewis. And therefore, I would like to know if you have a special program to control the rest of the esophagus and to prevent Barrett esophagus due to the reflux after an Ivor-Lewis procedure.
Yeah.
Who wants
It's a
to
very good
answer
question.
that? We do not perform Ivor-Lewis, but who does?
Eu estou numa live e depois eu te ligo.
I don't know if Professor Rubens wants to mention about, we have an experience at our service after esophagectomy through the achalasia patients, end-stage achalasia patients, who did develop Barrett's esophagus at the remnant esophageal stump. So we usually keep these patients with PPI usage after the esophagectomy. And hello.
Okay, go ahead.
So we keep these patients under PPI after the esophagectomy. We didn't perform Ivor-Lewis, just McKeown, but even so, we have some cases of esophagitis and Barrett's esophagus in esophageal remnant stump. So we did these patients, we keep with PPI.
Sergio,
yeah.
You mentioned those cases. The type of the procedure was totally different at that time. In the past, we pulled up the entire stomach with pyloroplasty. And those patients followed up, developed Barrett's esophagus in the cervical stump in 50% after 10 years. So when we changed it for a very thin gastric conduit without pyloroplasty, this decreased dramatically. We didn't find any more Barrett's in the cervical stumps as we usually did in the very past in those mentioned cases. So the type of the
surgery
conduit and not doing any more pyloroplasty probably changed this, and we can't see anymore anything like Barrett's in the esophageal stump as we did in the past.
May I do a comment?
Yes.
Okay, these patients that are referred now are patients with a grade 4 achalasia, with resection of the esophagus. And they were followed for more than 10 years with very, very, very long follow-up. And we have 37 patients with Barrett's esophagus in the cervical stump, McKeown resection. And in these cases, as Professor Rubin said, the stomach was very big at that time, and with pyloroplasty, and we have reflux of acid and the biliary juice. So it started, the histology was in the first 5 years. We have only columnar epithelium. In 5 to 7 years, we have the beginning of metaplasia, and we have 2 cases of a carcinoma in the stump, one 15 years after, and another one 22 years after. Both was resected endoscopically. So that means that when you follow Barrett's, you have to go to a long follow-up, because we show in these cases, these cases were published in 2004, more or less, I don't remember very well. But you see, you have to follow the patients, and you have the risk of cancer many years after.
Thank you. Italo?
Bruno. Yes, my comment is regarding the management of long segment Barrett esophagus. I want to put in consideration 3 points. One point is the physiopathological mechanisms that promote the development of Barrett esophagus. Is bile, acid, and incompetent lower esophageal sphincter. And then for management, for treatment of the disease, we must take in account this point. Second, medical treatment failed in order to stop the bile reflux, and also is maybe insufficient for control the acid reflux also. First, fan duplication alone, Nissen fan duplication, fails more frequently in patients with long segment Barrett esophagus. 3 or 5 times more failure after fan duplication. Then, in our strategy, you know, with the Professor Chendes in Santiago, in the University of Chile, we have suggested to perform another type of surgery in order to stop the chain of the development of the progression of the disease, in order to prevent acid and bile reflux. I know we have a lot of surgeon and physician against our position, our strategy. But we think that with a surgical procedure combined fund duplication plus acid suppression and bile diversion technique is the best option for treat this patient. We have published a lot of paper in order to convince the esophageal community in this strategy, but up to now the controversy remain. That is our position in this patient, and in this patient, 20 years with medical treatment. Why this patient was not operated before in order to stop the sequence of the progression of the disease? That is my comment.
Just to remember you that this patient came with the elevated lesion from the outside. We are not following this patient in this discussion.
But 20 years before, start with
okay, but this was another service. This is
okay.
I cannot discuss that.
There is another comment from Parupudi. Pyloroplasty and subsequent bile reflux seems to be the key beside the refashioning tubular gastric conduit. What we have to mention that in the new very thin tube like Dr. Saloom referred, we do not perform any more pyloroplasty. That's right, Rubens? Okay, so let's see the other question. Endoscopic treatment surveillance, we talk about severe type 1 adenocarcinoma, staging, treatment options, and best practice. Any comment about strategies for severe 1 who perform gastrectomy with distal esophagectomy for severe 1? Nobody does? Everybody perform esophagectomies?
Yeah, for CVIT 1.
Who is talking? Matthew?
Matthew, yeah.
Yes, please. Yeah.
I was saying for a CVIT type 1, I would always do an esophagectomy.
Esophagectomy with Iber-Lewis, isn't it? Yeah.
Yeah.
Dr. Jung, do you want to make any comment? Italo never performed pyloroplasty either.
Yes.
Okay. Any other comments?
I can make a comment.
May I? Oh, sorry, Andrew, you go.
Yeah, about pyloroplasty. In 1989, I went to Japan and I stayed with Professor Akiyama for 3 months. And I discussed it with him. And he said, well, I started doing this. And then I moved it to not doing pyloroplasty. And if I have some problems of gastric emptying that's lower than 10%, and they used to dilate with the finger during the operation, he said, okay, I don't do anymore the pyloroplasty. And if I have some problem, I go to endoscopy and I make dilatation of the esophagus. And nowadays, if you are a very difficult disease, you can make endoscopic pyloroplasty. I'm totally against at this moment of pyloroplasty. Totally against.
Dr. Tsiafilopoulos has a question. How do you perform? How do you perform? How do you define gastric emptying? How do you define gastric emptying problems? Who wants to answer that? Gastric emptying problems. I can ask it. I can tell it. We perform an X-ray and contrast X-ray, and we see the developing time of emptying of the stomach. So we like to perform a senior radiological screen. Too late? Too late for what?
Bruno.
Yeah.
I can tell something about this.
Yes,
Many
please.
years ago, I presented a study in the World Congress of IAS, the World Congress of International Society of Disease of the Esophagus. I performed a study with scintigraphic emptying of comparing gastric ascensum and colon interposition. And this group have not any difference about the gastric emptying. When you do the gastric ascensus to the cervical with cervical anastomosis or gastric interposition, because when you perform a straight long tube like Ruben Salum suggested, the gastric emptying is very good, and it is not necessary to perform pyloroplasty. And then that is our position, because by radionuclide assessment, the gastric emptying is so good, and with gastric tubulization.
Matthew, would you like to make a comment?
Yes, please.
Please.
It just relates to an earlier sort of discussion about the surgical management of reflux in the management of the long segment Barrett's. Everyone seems to be using the term fundoplication or Nissen fundoplication as the surgical management of reflux, but I think we can't forget about the hiatus hernia. Effective surgery involves repairing the hiatus hernia properly and restoring the GO junction to the abdomen. and combining that with a fundoplication, whether that's a partial or a complete fundoplication. So just saying fundoplication, I don't think maybe it's just semantic, but trying to get the right terminology. It's a hiatus hernia repair and fundoplication. And perhaps if you're only doing the fundoplication, that might explain why the reflux control isn't as good. And my only other comment was, I think maybe I was taken out of context previously, but I wasn't being critical at all about this case. I think you did very well in the COVID sort of era, I guess, in managing this case. And I don't think that this is sort of can be sort of looked negatively upon endoscopic management because you weren't able to complete your endoscopic management. But we didn't really talk about what do you do now in the COVID era, like moving forward, how are we managing these patients? So just those two comments.
May I do a comment, please?
Excuse me?
Bruno, may I do a comment?
Yes, please. Who is talking?
Denis Collet.
Oh, yes, please.
Yes. Regarding the gastric emptying and reflux after an esophagectomy, sometimes we have a patient with a very poor results, with a very big problem of gastric emptying and reflux as well. And it is not frequent, but we have did it 10 or 12 times. Several years after the esophagectomy, we put the gastric tube on a Roux-en-Y loop to like a duodenal diversion. First, to improve the gastric emptying, and second, to prevent the reflux of the bile reflux. And in most of the cases, it improves the quality of life of those patients who can resume a quite normal oral feeding.
Okay, thank you. There is another question from Dr. Xiao. Any experience in the treatment of the refractory anastomositis or ulcer after esophagectomy? Anyone has experience with ulcer after esophagectomy in the gastric tube?
It's a very difficult point, because when you have a gastric tubulization, the amount of acid reflux is very low, but the presence of bile reflux is the problem. And then we have no satisfactory treatment, medical treatment. Maybe Gaviscon, maybe sucralfate, or maybe this is bile, I don't know, cholestyramine. But it's a very difficult point to treat this ulcer in the cervical anastomosis. And then maybe for Gaviscon or sucralfate. But PPIs, I don't think that works very well.
No. I had once a very difficult treatment of bile reflux in a gastric tube after 17 years of gastric tube in a benign situation. And then I performed a duodenal switch.
Okay.
With Roux-en-Y duodenal switch. And it went very well. And it's an anecdotal solution, but it's a solution in a very refractory bile reflux. Yes. It's an option. It's an option. Idea. Duodenal switch.
Good idea.
Okay, people.
Also check for H. pylori and make sure it's not smoking.
Yeah, I'm happy to make a comment. So I'm a gastroenterologist. We've treated about 400 patients with dysplastic Barrett's with generally a combination of EMR and RFA over about 12 years. So we've got quite a big experience now, including about 75 cancers. And so I think I want to make two comments. One is in terms of follow-up. So I think there's two times when they get recurrence. One is early, which I think just represents that there's some dysplastic tissue that hasn't been removed. And they pop up within the first 12 to 18 months. And then others are late, even as late as 10 years, when they can be well away from the original lesion. But I think that one of the keys is EMR. So I think when I looked at those, I mean, I think this was a very well done case, and obviously the difficulty with follow-up was a major problem. Clearly that would have been identified much earlier otherwise. But I did feel myself, the thing I would have done a bit differently is on that initial follow-up or the one after, with that area that was raised, it's surprising the biopsies were normal, but you definitely can get tumor under the surface. That's, I think, not uncommon. And I think that any tissue that is elevated, even if the biopsies are normal or the surface is normal, I think EMR is extremely important, especially when you've had cancer initially. I think that that makes it a lot more likely there will be recurrence. So I think that any elevated lesion in follow-up, I think needs to be removed by EMR. And the second thing is in regard to reflux treatment. So I mean, I'm not a surgeon. We see the role of surgical treatment for reflux for the ones that don't respond to PPIs. But I mean, obviously a lot of these patients have bad reflux, and I think PPIs, often they need a lot of fine tuning. So I think most of them need twice daily high dose PPI taken before food. Sometimes esomeprazole is more effective than, say, pantoprazole. I mean, it varies, but I would say that's often the case. Some of them also need ranitidine before bed, and some of them need sucralfate as well. But I think if you really treat them very carefully, then it's probably only 5% that actually need a fundoplication, in my experience.
Thank you, Andrew. Any other comments? Would like to talk about CIVAT2 adenocarcinoma. Fully agree with Dr. Taylor. Okay. Triathylopoulos, agree with you, Dr. Andrew.
Thank you. Radiologist, different perspective.
Yes. Is there anyone who wants to comment about CIVAT2 adenocarcinoma, esophagectomy or gastrectomy with distal esophagectomy? What do you perform? Anyone experienced with CIVAT2? No? So I have to ask to Rubens, what do you do?
Well, you know very well, we
I know.
Often we do much more esophagectomy with a very extended proximal gastrectomy, like a subtotal proximal gastrectomy, and a reconstruction with a very thin gastric conduit. We can do for CIVAT2 by transthoracic or even by transhiatal approach. Because we don't need a very upper dissection in the thorax. So in elderly patients, we do this by transhiatal approach.
Who still perform transhiatal approach? Let me see. Nobody does? Not anymore? Transhiatal approach for cardiac cancer?
May I have a question?
Yes, do it.
Maybe Professor Salum can tell something to us. He's participating in a group with German and Holland surgeons and try to make a transhiatal dissection and by robotic surgery through the abdomen and through cervical area, dissecting all lymph nodes without thoracotomy. That is lowering the pulmonary complications of any type of thoracic abscess. So he went to Germany and they were discussing this, and there was a discussion in cadavers, and they published this. Maybe you can do some comments about this.
Yes, we did it with a group from Netherlands with Richard Heisenberg and Peter Grimm and other colleagues. But with two robot system, one from the neck with the single port robot system that is not available for clinical procedures, and at the same time by the abdomen with an XI robot system. And this is feasible. The dissection coming with the single part robot system from the neck, it's surprisingly very good. We can dissect till the carina very well, even the infracardial nodes. But this is now still experimental. We are doing, as I told, robotic transhiatal esophagectomy with cervical video dissection, and this is we performed in patients up to 85 years old in 4 patients, and they did very well. All of them were severe 2 adeno with a very good performance with this kind of operation, but a few number of cases, just 4.
Thank you, Robert. Okay, people, everybody, okay? I would like to ask Frederick if Professor Julie wants to make any comment.
Robert, can you unmute for the conclusion?
Your micro, Robert, your micro.
Yes, I followed with great attention all the elements of the discussion and the comments that were made by our friends from various parts of the world. Of course, we know that the discussion that were organized before already gave a good panorama of what is multidisciplinary esophagology. But we can tell that today, this 11th discussion was certainly very well in line with what we could expect from its organizers. I mean, the São Paulo school and all those who came across various parts of the world to give their opinion and their comment. Well, I thank Bruno with his friendly personality, who was able to highlight with his multidisciplinary panel the problems we all share for a benign disease, gastroesophageal reflux, when it evolves to Barrett's esophagus, and of course, especially when the development is toward adenocarcinoma. The discussion, we can say, was extremely lively. I thank you, all those who were coming to the discussion even late in the day. I'm speaking of those in Australia, those in Malaysia, and of course those in the United States who got up very, very early today. And the discussion was extremely lively from beginning to end. And the enthusiasm the panel members was shared, I think, by everyone in the virtual floor, which comes and increases each time, discussion after the discussion from various countries of the world. What I wish for the end of this session is to express and to highlight something. First, the recording. The recording of the session will be made thanks to the invaluable, endless effort of Frederick, who the president of the OESO Foundation and who is the organizer of this session. And second, the paper You must know that the paper from this session could be drawn up and submitted to be published in what is called the Stanford Multidisciplinary Seminars, the editor of which is George Triadafilopoulos from Stanford. And this is published in the framework of the journal Digestive Diseases and Sciences. All those who organized a session before are aware of this. I urge them to send their papers to George Triadafilopoulos that you can see here. And it is a very interesting journal, which is published by Springer, publisher. And I think that the team in São Paulo will comply also with the task of putting together the main parts of the discussion in a paper and send it for review to George Triadafilopoulos or to me, if you prefer. Well, now it's vacation and that's expecting some new and very hot debates in the future for the next discussion to be held, and that will take place in September onwards. Thank you, Bruno. Thank you, all your team, and thank you to all of you for your participation once again in this brilliant discussion. Thank you.